HDL cholesterol is the secondary target for therapy, and this is particularly helpful in patients with high TG where LDL cholesterol cannot be calculated. The non-HDL cholesterol can be obtained by subtracting HDL cholesterol from total cholesterol, and the target for them can be easily remembered as 0.8 mmol/liter above the individual LDL target for the cardiovascular risk category, as shown before. Now, patients with type 2 diabetes often have atherogenic type of dyslipidemia characterized by high TG and low HDL cholesterol. For these patients, we should emphasize on optimizations of their diabetes control as well as institute intensive lifestyle modifications. Very high TG, above 5 mmol/liter, are associated with increased risk of pancreatitis, so it's important to exclude those treatable secondary causes such as thyroid disease, alcoholism, or interfering drugs. Now, fibrates and omega-3 fatty acids are the mainstay pharmacotherapy for patients with high TG, and they are used in combinations with statin. For fibrates, subgroup analysis of cardiovascular outcome trial has shown beneficial effect for patients with high TG and low HDL cholesterol. In addition, fenofibrate has also been shown to reduce diabetic retinopathy progressions in those at-risk patients. Icosapent ethyl and omega-3 fatty acid has been shown at a dose of 2 gram BD in combinations with statin, again, is effective in reducing cardiovascular events in very high-risk patients category. So in summary, hypertension, dyslipidemia, and type 2 diabetes mellitus are indeed the evil triads, and aggressive control of these 3 major cardiovascular risk factors should be part of our comprehensive diabetes management care plan. The guidelines remind us to screen for hypertension and to initiate treatments when systolic blood pressure is above 140 or diastolic above 90. Blood pressure should be treated to target, but we must not treat below 120 systolic or below 70 diastolic to avoid the J-curve phenomenon. Now, statin has been well established as the agent to confer cardiovascular protections for patients with type 2 diabetes mellitus. In those very high risk of cardiovascular disease, there's now evidence for even more aggressive lowering of LDL cholesterol through intensive lipid lowering therapy. With that, I thank you for your attention.
Thank you very much, Dr. Florence, for that timely reminder that type 2 diabetes comes together and clusters together with other cardiovascular risk factors and really should not be just glucose alone, that it is imperative that we also aggressively manage blood pressure as well as lipids. And you have taken us through the current thoughts on what blood pressure targets to aim for. Without further ado, I'd like to introduce the next speaker, Professor Chan Wah Keong. I wish he were my relative. Unfortunately, he isn't. He is a consultant gastroenterologist and hepatologist in the University of Malaya Medical Center, and his key interest is in non-alcoholic fatty liver disease. So he's very well positioned to take us through NAFLD and type 2 diabetes, 2 sides of the same coin. Prof. Chan.
Hello and good day, everyone. First of all, I'd like to thank Professor S.P. Chan for this invitation to give the talk today in conjunction with the launch of the 6th edition of the Clinical Practice Guideline for Type 2 Diabetes Mellitus 2020. The topic that has been given to me is NAFLD and diabetes, 2 sides of the same coin. What is NAFLD? Non-alcoholic fatty liver disease, or NAFLD, encompasses a spectrum of liver conditions that are characterized by excess accumulation of fat in the liver. The diagnosis requires exclusion of significant alcohol intake and other causes of chronic liver disease. However, this is not in line with the reality that more than one cause of chronic liver disease may and often coexist in the same patient. Mafauzy is also recognized as the liver manifestation of metabolic syndrome. It is closely related to obesity and the metabolic syndrome. However, the term Mafauzy does not in any way attribute the condition to the underlying etiology. Because of these fundamental issues, a panel of international experts has proposed a new term called metabolic dysfunction-associated fatty liver disease, or Mafauzy. Mafauzy is defined by a set of positive criteria and is diagnosed in persons who have hepatic steatosis detected either by imaging, blood markers, or by histology, if the person has diabetes mellitus, is overweight or obese, or has two of the criteria listed in the green box, reflective of metabolic dysfunction. These are standard criteria for the diagnosis of metabolic syndrome, and in addition, two additional criteria which include elevated serum highly sensitive C-reactive protein and elevated HOMA-IR. For the purpose of this talk, I'll be using the old term Mafauzy. What is NASH? Non-alcoholic steatohepatitis, or NASH, is the more severe form of Mafauzy that is defined histologically by the presence of lobular inflammation and hepatocyte ballooning. Patients with NASH are more likely to develop liver fibrosis and cirrhosis and hepatocellular carcinoma. Why is Mafauzy important in patients with type 2 diabetes mellitus? Mafauzy is extremely common among patients with type 2 diabetes mellitus. As you have heard earlier, Mafauzy is considered as the liver manifestation of the metabolic syndrome, while type 2 diabetes mellitus is part of the metabolic syndrome. You can say that the two conditions represent two sides of the same coin. In this study that was done in the diabetes clinic of my hospital, you can see the prevalence of Mafauzy diagnosed by ultrasound is nearly 50%. In a subsequent study where fatty liver was diagnosed by control attenuation parameter, which is a bit more sensitive than ultrasonography, you can see that nearly 3/4 of patients in the same setting had Mafauzy. Not only is Mafauzy highly prevalent among patients with type 2 diabetes mellitus, patients with type 2 diabetes mellitus are also more likely to have more severe Mafauzy. In the same study, you can see the prevalence of advanced liver fibrosis diagnosed by liver stiffness measurement was over 20% among patients with type 2 diabetes mellitus. And among those patients with elevated liver stiffness measurement more than 8 kilopascal, who were referred to the gastroenterology and hepatology clinic and who underwent liver biopsy, you can see that the majority of them had NASH and some degree of liver fibrosis. Furthermore, nearly more than 1/3 of patients had advanced liver fibrosis based on liver biopsy. Ladies and gentlemen, you can see that Mafauzy is highly prevalent among patients with type 2 diabetes mellitus, and type 2 diabetes mellitus is a risk factor for more severe Mafauzy. This is why Mafauzy is important among patients with type 2 diabetes mellitus. So how do we assess patients with type 2 diabetes mellitus for Mafauzy? You can do that by simple blood tests like a liver function test and a platelet count. Patients who have normal ALT and AST can have repeat of these tests annually. For those patients who have elevated ALT and AST, these patients may have NASH. However, it is also important to exclude other causes of hepatitis which are common, like hepatitis B virus infection, hepatitis C virus infection, drug-induced liver injury, as well as alcohol. Patients should also have ultrasound examination to diagnose fatty liver and to exclude focal liver lesion. Patients in whom Mafauzy has been diagnosed should be given lifestyle advice, which I'll show to you afterwards that it is effective for the treatment of Mafauzy. And the ALT and AST level can be repeated after 3 to 6 months. Patients with persistently elevated serum ALT and AST level should be considered for referral to a gastroenterologist or hepatologist. Serum ALT and AST level together with the platelet count can be used for calculation of the fibrosis 4 score. The fibrosis 4 score is an excellent tool to exclude advanced liver fibrosis. Patients who have a fibrosis 4 score of less than 1.3 is very unlikely to have advanced liver fibrosis. And this fibrosis 4 score can be repeated every 2 to 3 years in that case. On the other hand, patients with a fibrosis 4 score of 1.3 or greater are at intermediate or high risk of advanced liver fibrosis. These patients should be referred for liver stiffness measurement and can be considered for referral to a gastroenterologist or hepatologist. Liver stiffness measurement is a simple and reliable non-invasive test to diagnose liver fibrosis. I'll show you how it is done. Patient will come for the examination fasting for at least 2 hours, and the intercostal space over which, under which the liver lies will be identified. The probe has got a mechanical actuator that produces a vibration that travels through the liver tissue. On the same axis, there's an ultrasound probe which measures how fast the vibration travels through the liver tissue. And this is translated by the computer into a liver stiffness measurement. Typically, we will record 10 valid measurements, and the value that we obtain will be used to estimate the degree of liver fibrosis. One of the important things to look at to interpret this value is the IQR over median. The IQR over median tells us how far the values of the measurement disperse from each other. We generally take an IQR median of less than 30% for the examination to be considered reliable. So for example, in this particular case, after we have got 10 valid measurements, we will look at the IQR over median. In this case, is 4%, which tells us that the value is, the examination is reliable. My apologies, 5%. And the liver stiffness measurement for this case is 15.4 kilopascal. How do we interpret this? We will look at this in the next slide. Patients with liver stiffness measurement less than 10 kilopascal are unlikely to have advanced liver fibrosis. Patients with liver stiffness measurement between 10 to 15 kilopascal may have advanced liver fibrosis and requires monitoring, for example, repeating after 1 year. These patients should be considered for referral to a gastroenterologist or hepatologist. Patients with liver stiffness measurement more than 15 kilopascal are likely to have advanced liver fibrosis, and these patients should be considered for liver cancer surveillance. They should also be considered for referral to gastroenterologist or hepatologist. Patients with liver stiffness measurement more than 20 kilopascal, especially in the presence of thrombocytopenia, are likely to have clinically significant portal hypertension. They should be considered for liver cancer surveillance and varicose screening and should be referred to a gastroenterologist or hepatologist for further management. So what can I do for patients with type 2 diabetes mellitus and NAFLD? These are the recommendations in the clinical practice guidelines. Lifestyle intervention is the mainstay of treatment for NAFLD. In this study on nearly 300 patients with biopsy-proven NASH who underwent lifestyle modification over 52 weeks and had a repeat liver biopsy after that, weight loss of at least 10% has been shown to result in NASH resolution in 90% of patients and fibrosis improvement in 45% of patients. Ladies and gentlemen, I would like to summarize by saying that NAFLD is highly prevalent among patients with type 2 diabetes mellitus, and type 2 diabetes mellitus is a risk factor for more severe NAFLD. Therefore, it is important that assessment and identification of type 2 diabetes mellitus patients with more severe NAFLD is carried out so that these patients can be linked to care and treatment. And this assessment can be done with simple blood tests, fibrosis score, and liver stiffness measurement can be done when indicated. Last but not least, lifestyle intervention is the mainstay for treatment of NAFLD. Thank you very much.
Thank you, Professor Chan, for the talk on NAFLD. And Dr. Chan in his talk stressed how important to diagnose and detect patient NAFLD in patients with type 2 diabetes mellitus, in which many of doctors not doing this at the current practice. Our next speaker is Professor Nolaila Mustafa. Professor Nolaila currently head Department of Medicine, Faculty of Medicine, UKM, and he's also senior consultant and endocrinologist at Pusat Perubatan Tengku Mukris. And he's going to talk on the less spoken topic in diabetes mellitus. And this topic is a new topic in our CPG, in which diabetes and periodontal diseases. Prof. Nolaila?
Hi everyone, good afternoon. My name is Dr. Nolaila. I'm going to talk to you on diabetes and periodontal disease as the second topic of this guideline. This is the less spoken topic in those with type 2 diabetes or underdiagnosed in patients with type 2 diabetes. Periodontal disease is a chronic inflammatory condition comprising of gingivitis and periodontitis, and therefore oral health education should be provided to all with type 2 diabetes, as the management of periodontal disease will improve metabolic parameters in those with type 2 diabetes. Physicians and healthcare professionals should investigate the presence of periodontal disease as an integral part of type 2 diabetes care visits, and prompt referral should be made to the dentist if there's any presence of periodontal disease. For people with newly diagnosed type 2 diabetes, referral for periodontal examination should be done. An annual review is recommended. People with type 2 diabetes has a 2 times more severe periodontal inflammation or periodontal destruction than those without type 2 diabetes. And this is because the pro-inflammatory mediators within the inflamed periodontal tissues lead to insulin resistance and worsening glycemic control. And the presence of periodontal disease in type 2 diabetes release interleukins and tumor necrosis factors that worsen insulin resistance and further worsen the metabolic control in those with type 2 diabetes. Increased A1C as little as 0.3% has been shown in type 2 diabetes patients with severe periodontal disease. And the presence of comorbidities in type 2 diabetes, such as diabetic kidney disease, have shown to increase all-cause mortality by about 23% and cardiovascular mortality by 16%. Therefore, the care of type 2 diabetes and periodontal disease should be done together or collaborated between healthcare providers and oral healthcare providers for holistic care of type 2 diabetes patients, because it will then improve glycemic control and metabolic control in type 2 diabetes patients. Reduction in A1C between 0.3% to 0.5% with periodontal therapy like scaling and root surface debridement will improve clinical periodontal parameters even in poorly controlled type 2 diabetes patients. And to summarize, the successful management of periodontal disease will improve metabolic parameters, and the presence of periodontal disease should be integral part of type 2 diabetes care visits, and annual periodontal review is recommended in all type 2 diabetes patients. I would like to acknowledge Professor Ratna Devi for preparing the slides and also contributing to this guideline. Thank you.
In which dental care improve diabetes control. Our next speaker is Associate Professor Dato Malik Muntas. Datuk Malik now is a consultant endocrinologist at Island Hospital and also lecturers in Penang's Medical College. His topics for today's hot topic will be on cardiovascular disease in diabetes mellitus beyond glucose lowering. Prof. Malik, all yours.
Assalamualaikum and good afternoon. Welcome to this hot topics in diabetes, and we're talking about cardiovascular risk reduction beyond glycemic control. I'd like to thank MEMS for the opportunity to talk to you. I'd also like to thank my team of talented endocrinologists who helped me help prepare this section with regards to medication in diabetes. So I'd like to thank everyone. And I'm going to share my slides. Okay, I'm going to talk about CVD risk reduction beyond glucose lowering. And basically, this is an important topic because there are very high rates of diabetes. And as you've heard from previous speakers, high rates of diabetes in the population translates to cardiovascular disease. When you have prediabetes and diabetes, there is a 2 to 3-fold increase in the CVD risk, and 60% of patients eventually die of CV complications. So it's something that we need to recognize early and treat to prevent these deaths. And in 2016, 2017, when we looked at the acute coronary syndrome admissions, about half these patients were actually diabetic or were newly diagnosed diabetics. And in fact, the other risk factor which was noted was hypertension. So hypertension, diabetes is actually very prevalent in these patients. Now, when you look at the National Diabetes Registry, which encompasses a huge number of patients, they looked at 180,000 patients or more, and they found that if they looked at patients with diabetes and coexisting medical conditions, hypertension was seen in 80%, the mean blood pressure of 135/77. High cholesterol was seen in a significant number, again 74%. Majority of patients were overweight or obese with a BMI of 27.8, and they had poor diabetes control. In fact, about a third only achieving their HbA1c targets of less than 6.5%. So large numbers of patients actually have significant comorbidities. So when you see these kinds of patients, the choice of medications is guided by patient profile. In high-risk patients, the choice of medications basically should be evidence-based. And the classes which have shown the greatest benefits in patients with cardiovascular disease include SGLT2 inhibitors, as well as GLP-1 receptor agonists, or GLP-RA as they're going to be known. When considering initiation of SGLT2 inhibitors or GLP-1 RAs for CV risk reduction, then really we recommend choosing agents with proven CVD benefit. And there are a few, as I'm going to show you. And you should also make sure that they have received a labeled indication for CV benefit from our local NPRA. So specific patient profiles are important. And if you look at our CPG, we have these algorithms which help guide the practitioner. So basically, looking at the profile of your patient, you can choose which algorithm, which flow you want to go down. We're focusing on the right side of the screen, but we are looking at high CVD risk, ASCVD, atherosclerotic CVD, and heart failure. So these patients. So when you talk about GLP-1 receptor as well as SGLT2, the evidence is strongest that in these category of patients, these are your first choices. So GLP-1 RA and SGLT2 inhibitors in patients who have either established heart disease or at high risk, and in patients with heart failure, based on the current evidence and the need for risk reduction, SGLT2 inhibitors and GLP-1 receptor agonists, again, are medications of choice. You need to examine your patient's circumstances and see whether the other factors will allow the use of these medications, particularly if cost is an issue. So when you listen to talks, when you read data, you hear this term MACE, major adverse cardiovascular events. And MACE basically is a triad of cardiovascular death, non-fatal myocardial infarction, as well as non-fatal stroke. And the idea is that if you have this term, then there is some degree of consistency across clinical trials and making them slightly more comparable. There is another component which patients, it's a MACE plus if you want, and basically are looking at hospitalization, revascularization procedures, as well as heart failure as one of the events. So MACE is usually primarily defined at the beginning of the trial, and these are the outcomes which we look for. So individual components of MACE may actually confer some degree of benefit to these patients. So if you look at completed CVOTs, cardiovascular outcome trials, there have been many. For the DPP-4 inhibitors, they have demonstrated CV safety, but no MACE benefit. GLP-1 and the others I'm going to talk about in the next few slides, but effectively, DPP-4 inhibitors are safe to use in patients with cardiac disease, but do not confer any MACE benefit. What about SGLT2 inhibitors? In Malaysia, we have empagliflozin, canagliflozin, dapagliflozin, and more recently, ertugliflozin. They have large studies, and basically, two have shown MACE benefit, empagliflozin and canagliflozin. So they have also, that's a rationale for incorporating these drugs into the study. And if you look at dapagliflozin and empagliflozin here, they have dedicated heart failure studies with reduced ejection fraction. And they have shown hospitalization reduction in heart failure as well as reduction of CV death to a value of around about 25%. So again, these two studies were positive, showing cardiovascular benefit. Now, if you look at the GLP-1 receptor agonists, we have many in the market: Lixi, exenatide, liraglutide, semaglutide, dulaglutide. Semaglutide oral will come in due course. Albiglutide is no longer available. And if you look at the numbers there is significant MACE benefit for liraglutide, semaglutide, as well as dulaglutide. And again, these studies are positive with MACE benefit. All of the GLP-1 receptor agonists are CV safe. So if you look at the MACE outcomes, again, EMPA-REG and CANVAS showed significant reduction in one of the components of MACE, and CV death reduction was seen particularly with empagliflozin. If you look at heart failure reduction, you see this across the board. All the SGLT2 inhibitors actually showed benefit as far as heart failure risk reduction was concerned, and all-cause mortality was seen, or reduction was seen in empagliflozin. So again, this is the rationale for using these medications in such patients. If you look at GLP-1 receptor agonists in terms of CV outcome, if you look at the trials that demonstrated superiority with a primary composite outcome, primary MACE, then basically the composite MACE was shown to be beneficial in liraglutide, semaglutide, dulaglutide, as well as albiglutide, which is no longer available. So these are the drugs which have the label indication for CV safety and CV risk reduction. And if you look at the individual components of MACE, again, LEADER showed some benefit, semaglutide showed some benefit, as well as oral semaglutide. And if you look at heart failure generally, this was not generally a feature of the GLP-1 receptor agonists, unlike the SGLT2 inhibitors. So overall, in conclusion, when we looked at historical CV outcome trials, we demonstrated only microvascular benefit. Really, there was not much improvement in the way of all-cause mortality or MACE. But the recent CV safety studies with antihypoglycemic medications actually demonstrated CV safety. GLP-1 receptor agonists, CVOTs were mixed. CV benefits seen in liraglutide, dulaglutide, and semaglutide, whereas lixisenatide and exenatide did not show any benefit but showed safety. SGLT2 inhibitors showed CV benefit demonstrated by EMPA and canagliflozin, and dapagliflozin showed CV safety and some of the heart failure stuff that I showed you earlier. So in conclusion, in these high-risk patients with high risk of CVD, atherosclerotic cardiovascular disease, and heart failure, there is a significant shift in the way we treat these patients with the use of GLP-1 receptor agonists as well as SGLT2 inhibitors, because these have shown CV benefit in such patients. So with that, I'd like to thank you very much and hand the podium back to our chairperson. Thank you very much.
Thank you very much, Dr. Malik, for taking us through a whole bunch of really important key landmark trials that we've had in the last 5 years, and how it's really changed the way in which we consider management of our patients with type 2 diabetes and cardiovascular disease or high risk for CVD. We would like to continue with this hot topic session, and I'd like to introduce to you Associate Professor S.K. Lim, consultant nephrologist, again at PPUM. He's the head of the nephrology unit and is very heavily involved in a lot of research trials with regard to diabetes, renal disease. And without further ado, he's going to take us through diabetic kidney disease, changing the trajectory. Back to you, Prof. S.K. Lim.
Good afternoon. I'm Associate Professor Dr. Lim Sukund, nephrologist from UMMC. I'm given the task to actually update you on diabetic kidney disease, changing the trajectory. So these are the 5 highlights I'm going to talk about for the next 10 minutes. So highlight number 1, we use diabetic kidney disease as a term to replace diabetic nephropathy we used in 2015 CPG. The reason being, we know that diabetic nephropathy is a histological diagnosis, and in clinical practice, we only biopsy a minority of patients with diabetes and kidney disease. And diabetic kidney disease is a more appropriate term because it represents a group of diabetic patients who presented with kidney disease. And from all the reports, it's estimated that 20 to 40% of patients with diabetes will have diabetic kidney disease. Highlight number 2, we observe a paradigm shift from glucose-centric to organ protection. If you look at 2015 CPG, we highlighted the importance of blood pressure and blood sugar control, as well as the use of RAS blocker to reduce proteinuria as 3 main strategies to retard progression of diabetic kidney disease. In 2020 Type 2 CPG, we highlighted the importance of selection of appropriate anti-diabetic agent for organ protection, in addition to optimal glucose control. If you follow all the studies that has been done for diabetic kidney disease, we definitely will realize that there's always an unmet need in diabetic kidney management. We have been searching for a new agent which can provide renal protective effect for the past 20 years. So the 3 trials on the left are the landmark study, which has been well established for the past 20 years, renowned using losartan, IDNT, irbesartan, as well as advanced, published in 2007, not focusing on a specific agent, but highlight the importance of intensive blood pressure and blood sugar control. But in 2019, Credence and 2020 DAPA-CKD are the 2 SGLT2 renal outcome study that has been published. If you observe in these 2 studies, more than 95% of patients has been put on RAS blocker, and with a median follow-up of 2.5 years, we can see a significant impact on renal outcome. So these are the 2 renal outcome trials for SGLT2 I talked about. If you can see that both the trials recruited patients with stage 3 CKD with significant proteinuria up to 1 gram a day. And it's important to highlight that Credence recruited 100% of diabetic patients, but DAPA-CKD, only 2/3 of patients were diabetes, but another 1/3 are non-diabetic. But both the study, with a median follow-up of 2.5 years, it shows a significant risk reduction of 30% in Credence and up to 40% in DAPA-CKD. As we understand of renal physiology, we can see that SGLT2 inhibitor can restore tubular glomerular feedback by causing a vasoconstriction of the afferent arterioles, working together with RAS blocker to reduce intraglomerular pressure and albuminuria. So with this understanding, we have to take care of other factors that may alter glomerular hemodynamics. So in this particular context, I want to highlight the importance of diet. As we know, high salt diet as well as inappropriately high protein diet can increase intraglomerular pressure and worsen proteinuria. So in order to optimize the effects of SGLT2 as well as RAS blocker, we need to make sure patients are not taking high salt as well as high protein diet. So if you look at trials and put them into the spectrum of diabetic kidney disease, we can see that Credence and DAPA-CKD basically recruited patients with significant proteinuria. But does this mean that SGLT2 does not work in patients without albuminuria? The answer is not true. We do have other CVOT trials for SGLT2 which recruited patients with or without albuminuria. So if you look at this particular meta-analysis, it basically highlighted to us that renal protective benefits of SGLT2 appear to be greatest even in patients with preserved renal function, highlighting the important role of the use of SGLT2 in early diabetic kidney disease. If you look at the similar analysis for albuminuria, we can see the similar trend whereby renal protective effects of SGLT2 is evident even in patients with normal albuminuria. So taking all the evidence together in terms of renal protection, now we realize that SGLT2 not only proven to be effective for secondary prevention, but also for primary prevention of diabetic kidney disease. Highlight number 4, GLP-1 receptor agonist reduces progression to albuminuria in diabetic kidney disease with high cardiovascular risk, and the evidence come from REWIND as well as LEADER. So REWIND using dulaglutide and LEADER using liraglutide both show a significant impact on progression in albuminuria. So from the understanding of a mechanism of action, we know that GLP-1 receptor agonists can impact on the renal outcome through a direct effect as well as indirect effect. Direct effect is on the significant glycemic control, blood pressure control, as well as weight loss. But GLP-1 receptor agonists can also have indirect effect, for example, effect on hemodynamic effect, inhibition of the RAS system. More importantly, it can reduce oxidative stress as well as having anti-inflammatory effect. But whether all this will translate to a significant effect on the renal outcome, we have to wait for the dedicated renal outcome trials for GLP-1 receptor agonists. So all the evidence has translated to the change in the international as well as local CPG. On the left is a recently published KDIGO guideline for type 2 diabetes and chronic kidney disease. So they have actually positioned SGLT2 in the same level as metformin, highlighting the importance of the use of SGLT2 as one of the renal protective agents. Our Malaysian CPG for type 2 diabetes management 2020 also positioned SGLT2 as a second anti-diabetic agent after metformin. And it's important to highlight that for the meantime, most of the SGLT2, the eGFR threshold for initiation is 30 ml per minute. But based on KDIGO recommendation, we do not need to discontinue SGLT2, even the eGFR drift less than 30, and we only discontinue the agent when the patient is started on dialysis. Of course, this recommendation is based on the 2 published renal outcome trial, that is Credence as well as DAPA-CKD. Highlight number 5, we have placed rapid decline in renal function as the first criteria for nephrologist referral in this particular update, basically to highlight that the importance of a GFR trend or trajectory, more importantly, the absolute value of eGFR. So eGFR loss of more than 5 ml per minute per year or more than 10 ml per minute in 5 years is the important criteria for nephrologist referral. And of course, this may represent a diabetic kidney disease with rapid progressor, or it might be a diabetic patient who has glomerular nephritis who need further investigation. So these are the 5 highlights that I have talked about for the past 10 minutes. Thank you very much for your attention.
Thank you very much, Prof. S.K. Lim, for taking us through this, again, extremely exciting field with regards to diabetic kidney disease and changing the trajectory. I'm sure there are questions that we will have for you. Please, for those of you who are listening in, we are getting a lot of questions. We may or may not be able to answer all of them, but we'll certainly give it a good try. Please continue to bring in your questions. And without further ado, I have great pleasure to introduce the next speaker, Dato Dr. Zanariah Hussein, who's extremely well known to everyone. the head of Putrajaya Hospital, I think medical department, as well as head of endocrine services in KKM. And she'll be actually taking us through young onset diabetes, giving it your best shot. Here you go, Dato Zanariah.
Good afternoon. I'm Dr. Zanariah Hussein from Hospital Putrajaya. This afternoon, it is a pleasure to highlight a very important topic from our Type 2 Diabetes CPG 2020. And this is on new onset Type 2 diabetes and giving it your best shot in terms of early management. Type 2 diabetes is a progressive disease, and this slide actually puts into perspective very important points that needs to be considered. Glucose abnormalities are in a continuum from pre-diabetes to diabetes. Hyperglycemia is progressive, and this is contributed by the decline in beta cell function. There is a need to initiate medications to treat hyperglycemia, and it is important to address medications that minimize hypoglycemia, minimize weight gain, and along with that also to address multiple risk factors, particularly cardiovascular risk factors, and to monitor and screen complications of diabetes. There are several landmark clinical trials that shape our current treatment, understanding, and strategies for early type 2 diabetes management. It is important to recall the monotherapy trials, particularly the UK-PDS or the United Kingdom Prospective Diabetes Study, very importantly initiated in the 1970s, where newly diagnosed patients with type 2 diabetes failing diet control were actually put onto monotherapies and followed up for a long term. Subsequent to that was also the ADOPT trial, another trial of head-to-head monotherapies, looking at durability of glycemic control. Combination therapy trials then followed, and importantly, to highlight the GREAT trial, which is currently in progress and almost to be completed in 2021, looking at what add-on therapies following metformin would actually be best for durability of glycemic control. And a very important trial that I would like to highlight this afternoon is the VERIFY trial that recently reported the success of actually having combination therapy of vildagliptin and metformin versus metformin alone in early diabetes management. The UK-PDS is a very important landmark trial that showed us the monotherapies and in head-to-head trial. And it showed us that year after year that HbA1c inclined with whatever agent that was used. And this was most likely due to a progressive decline in beta cell function, as shown in this slide. And the UK-PDS also then showed us that there was a limited duration of glucose-lowering efficacy of any of these anti-diabetic monotherapies. And here it's important to highlight those three important main therapies used in the UK-PDS, which was sulfonylureas, metformin, and insulin. And in the UK-PDS, after 3 years, approximately 50% of patients could attain this goal with monotherapy. And by 9 years, this declined to approximately 25%. Thus, the majority of patients will need multiple therapies to attain and maintain good glycemic targets. This is the other trial I mentioned previously, called the ADOPT trial. It was a head-to-head trial in newly diagnosed patients using a thiazolidinedione called rosiglitazone versus a sulfonylurea, which was glyburide or glibenclamide, and metformin. Again, we see here, as in the UK-PDS, that along year after year in this trial, there was a gradual progression of the A1C to an increasing trend. And this was explained by a loss of beta cell function, whichever agent that was used. But primarily so, definitely glyburide or glibenclamide showed the most apparent decline in beta cell function. Insulin sensitivity also gradually inclined over a period of time. And as you can see also in this slide, it looked at the durability of glycemic control. As keeping to a monotherapy could only last 33 months with glyburide to actually keep the A1C 7% and below. With metformin, it took 45 months, and with rosiglitazone at that time, up to 5 years before there was loss of glycemic control. The GRADE study is very interesting and it's still in progress. And it is a study which recruited patients on metformin monotherapy of less than 5 years duration and looked at different add-on therapies, whether it be sulfonylurea, a DPP-4 inhibitor, a GLP-1 receptor analog, or in fact basal insulin. And the GRADE trial will actually complete in July 2021 and will then be able to tell us which is probably the best sort of combination or add-on therapy after metformin in patients with early diabetes. Now let me highlight to you the VERIFY trial. VERIFY standing for vildagliptin efficacy in combination with metformin for early treatment of type 2 diabetes. The participants in this trial were patients with type 2 diabetes who were drug naive or newly diagnosed with a disease duration of less than 24 months. Their A1Cs were between 6.5% to 7.5%. It was a 5-year multi-center randomized parallel group double-blind study with a primary endpoint of time to treatment failure. And this was defined as a HbA1c of more or equal to 7%. These were the baseline characteristics of the VERIFY trial, and we can appreciate the type 2 diabetes duration of only 3 years and A1C at baseline in both groups of just below 7% or 6.7%, an A1C that was mildly elevated and a level that you and I may be inclined to sometimes even wait and see. Now look at what happened with this trial. And we can see that those put on metformin monotherapy and actually optimized on that monotherapy actually had a time to treatment failure where their A1Cs went beyond 7% of 36 months or 3 years. But what if they were combined early with vildagliptin? And you can see such an apparent difference where the patients who were actually given an early combination therapy only failed therapy after 61.9 months, which is actually 5 years. And this actually had a relative risk reduction of a very significant level of almost 50%, which was highly statistically significant. Another study to highlight to all of you is also a study that was reported recently looking at the GP practice in the United Kingdom. It was purely an observational study where it looked at the importance of achieving an A1C of 7% and below within a year of diagnosis versus those that did not actually achieve an A1C of 7% and below. And these patients were then followed up for the subsequent years. And what was actually observed, and very importantly, is that those that were unable to achieve an A1C below 7% within a year of diagnosis had a significantly higher risk at 5 years of myocardial infarction of 67%, of heart failure of 64%, composite cardiovascular events of 62%, and stroke of 51%. Again, emphasizing the importance of achieving A1Cs to target as early as possible, especially in this case before a year ends following diagnosis. This is another slide that we have appreciated and we've learned from in the sense that we now know from the UKPDS and the DOP study and subsequently the other studies that followed on is that monotherapy failure is apparent, and that combination therapy is important in the management of type 2 diabetes, and this should be done early to achieve targets early so that complication rates can actually be reduced. Treatment in patients with type 2 diabetes should be individualized, and selection of oral anti-diabetic therapies would need to take into account several factors. We are aware of the multiple different groups of anti-diabetic agents. It is important to have optimal management of hyperglycemia. The overarching goal of glucose management is to achieve the best possible glycemic control with the fewest possible side effects. And this will require combination therapy utilizing agents with complementary mechanisms of action. This is the treatment algorithm for newly diagnosed type 2 diabetes in our new type 2 diabetes CPG. And this reflects the importance of actually the presenting HbA1c and the strategy of treatment. whether a choice of monotherapy with metformin for those with A1C of less than 6.5%, or those with higher A1Cs at presentation, whether a strategy of monotherapy, dual therapy, or combination therapy of oral agents and possibly even injectables should be used from the start. The general guidelines for use of oral glucose lowering drugs, very important to emphasize as I end this talk, is that early combination therapy that addresses different pathophysiological defects in type 2 diabetes should be considered in the newly diagnosed type 2 diabetes patients. Finally, it's very important to highlight a few issues regarding early treatment of type 2 diabetes. Oral glucose lowering drugs can be used as monotherapy or indeed early combination therapy of multiple oral glucose lowering drugs should be considered when necessary. As first-line therapy, metformin is the preferred choice. Medication regimens should address individual factors such as comorbidities, as well as risk for specific adverse drug effects. Importantly is that A1C remains an important target. If glycemic targets are not achieved, then intensification of treatment should be made every 3 to 6 months. With that, thank you very much.
Thank you for listening, ladies and gentlemen of the audience. So let's go to the next hot topic as we come to almost the end of this afternoon's really exciting session with the launch of our latest type 2 diabetes guideline. The next speaker is also a close colleague of mine. She is Professor Dr. Rohana Abdul Ghani. She's a senior consultant endocrinologist at the University UITM, and she heads the endocrine unit there. So she will be giving the topic with regards to the tailoring the right first injectable, an area that is really important now that we are in the era of non-insulin injectables. So let's hear from Prof. Rohana.
Assalamualaikum and good day. As part of the launching of the CPG, I'm Dr. Rohana Abdul Ghani from University Technology Mara. My topic for today is tailoring the right first injectables, and I'll be highlighting the rapid fire hot topics in the CPG updates. I'm going to start with this slide that depicts the different target organs in the pathophysiology of type 2 diabetes, focusing or leading towards hyperglycemia. It also illustrates the different medications associated in the treatment of type 2 diabetes, including some of the medications you're familiar with, including TZDs and the sulfonylureas, and of course metformin and the gluconides, but also the relatively newer medications such as the SGLT2 inhibitors, which focuses on the renal tubules, the incretin hormones, including GLP-1 receptor agonists and DPP-4 inhibitors. To answer that question, which injectable do you choose for your medications following optimal use of oral glucose lowering drugs? Options are such. GLP receptor agonists should be considered in patients who have concerns regarding hypoglycemia and weight gain. Insulin, however, has its role, and it should be initiated with a pre-bed insulin followed by the basal insulins if required, which I will dwell upon further on in the talk. Some of the updates in the CPG include some information on GLP-1 receptor agonists, including the fact that the efficacy involves lowering of HbA1c between 0.8 to 1.6% and lowering of body weight from 1 to up to 4.1 kilograms. However, the effects are dose-dependent, and the weight reduction is mainly due to a defect in satiety and delay in gastric emptying. The side effects, of course, are quite predominant on gastrointestinal effects, including nausea, vomiting, and diarrhea. The two new compounds we are introducing for this CPG include the dulaglutide and the semaglutide, highlighting the similarities between the two. Both are long-acting, once-weekly administration. However, there have been shown efficacy in terms of treatment as monotherapy, and this is superior to metformin, and also safe to be used in combination with metformin, some sulfonylurea, SGLT2 inhibitors, and also as addition to insulin. I would like to highlight that both compounds demonstrate cardiovascular outcome trials, which show significant reduction of primary 3-point MACE. patients who are to be initiated on semaglutide should have the progression of diabetic retinopathy monitored closely. Some precautions surrounding GLP-1 receptor agonists include the fact that they are not substitute for insulin. I would like to repeat that they are not substitute for insulin. GLP-1 receptor agonists should not be used in combination with DPP-4 inhibitors because they both belong to the same class of incretin hormones. Nausea and vomiting are common side effects, and any patients who are to be initiated on these compounds should be adequately consulted regarding these. Patients should also not be given a GLP-1 receptor agonist if they have history of pancreatitis, history of multiple endocrine neoplasia 2A or 2B, or family history of it, including medullary thyroid cancer as well. We would like to remind healthcare providers that in the use of GLP-1 receptor agonists, for CV risk reduction, we recommend using the compounds with proven cardiovascular disease benefits. Further general guidelines for use of oral glucose-lowering drugs for early or newly diagnosed type 2 diabetes patients. Early combination therapy, which addresses the different pathophysiological defects in type 2 diabetes, should be used in combination. And intensification of treatment should be made promptly without delay, and the medication regime should be re-evaluated at regular intervals of between 3 and up to 6 months, and adjusted as needed to incorporate the new patient factors that develop over time, including atherosclerotic cardiovascular disease, heart failure, diabetic ketoacidosis, hypoglycemic events, weight gain, and other social issues, including cost concerns and change in socioeconomic support. In regards to de-escalation of the treatment, this should be considered in patients who have achieved improvement in glycemic control successfully and successful weight loss. Also in change in glycemic controls, especially in the setting of elderly patients, development of new comorbidities and development of new side effects, and also treatment ineffectiveness. So medication should be adjusted accordingly. Even though glycemic targets are important to all of us, including patients and healthcare providers, patients who demonstrate or experience progressive weight gain and exacerbation of insulin resistance should have their medications re-evaluated, especially those patients who are overweight and obese at the start of the therapy. Caution needs to be exercised when intensifying insulin dose or regime, particularly paying attention to weight gain and unrecognized hypoglycemia or hypoglycemic unawareness. So this recommendation at the end of the section summarizes the points that I've highlighted above, including oral glucose-lowering drugs can be used as monotherapy or in combination. However, new intensification of treatment should be done rapidly or promptly in newly diagnosed patients. Metformin remains as the first-line therapy. Medication regime choices should address other comorbidities as mentioned above, and also risk for specific adverse drug effects, safety, and tolerability. Cost of medication should be given due consideration, and if targets are not met, the injectables including GLP-1 receptor agonists or insulin should be considered. And most importantly, HbA1c remains as the most important target and should be evaluated every 3 to 6 months. I'm just going to dwell on a little bit about insulin therapy. Initiation of insulin therapy should be considered in the following situations, including inadequate glycemic control on optimal dose and duration of glucose-lowering drugs, both oral and injectable. It should be used as a short-term treatment in patients who are experiencing acute illness or surgery, and also patients undergoing severe metabolic decompensation, including diabetic ketoacidosis and hyperosmolar hyperglycemic state. It can be used as initial therapy in newly diagnosed type 2 diabetes, especially if patients are presenting with symptoms of hyperglycemia and evidence of ongoing catabolism, including weight loss, and also when HbA1c exceeds above 10% or fasting plasma glucose of more than 13 millimoles per liter. It can also be used as part of early insulinization treatment regime. Figure 3.2 is an update from the previous CPG, which gives you a guide on what to do in terms of initiation and optimization of insulin therapy. Newly diagnosed patients or patients who have the indications which I had outlined above should be started on the basal insulin as the first box outlines, and followed by prandial addition of prandial insulins as required. Patients who experience fasting plasma glucose within target, but however experiencing high glucose levels throughout the day, can be considered with basal insulin analogs or co-formulations. It can be further escalated to be twice daily or 3 times daily using the analog insulins. Ultimately, the basal bolus regimen should be considered if patients are unable to reach glycemic target as desired. So finally, I would like to summarize with this slide, which highlights the 2020 updates in the CPG. The cost of medication should be given due consideration when choosing the treatment option. Medication regimen should address comorbidities such as atherosclerotic cardiovascular disease, heart failure, and chronic kidney disease. And if targets are not met after optimal combined oral glucose lowering drugs, consider adding the injectables. The GLP-1 receptor agonist should be considered in patients who have weight gain and hypoglycemic concerns, and insulin should be administered as indicated above. Again, I would leave you with this point that HbA1c remains an important target in the treatment of type 2 diabetes. And with that, thank you very much.
Thank you, Professor Hana. It was very well presented, and let's go on to the next session. It is the next and final, or the 10th of the sessions we have this afternoon. So it gives me the greatest pleasure of all to introduce a lady that really needs no introduction, the chairperson of the guideline herself and the current president of Malaysian Endocrine Metabolic Society, Professor Dr. S.P. Chan, who actually present the last session, which is focusing on what Prof. Rohana actually finished her last statement on, which is the importance of the HbA1c, whether it is still a target that we need to focus on. All yours, Prof. Chan.
Hello, good afternoon. I'm Dr. S.P. Chan. I will be talking about the last topic in this list of hot topics rapid fire. And it is concerning the topic of A1C. Many of you will be wondering, hey, is there a problem? The answer is yes. Because of the recent cardiovascular outcome trials, the recent diabetic kidney disease trials, there have been these drugs are able to protect the target organ irrespective of the A1C that was achieved. And therein lies some misunderstanding that could happen, right? So moving along, A1C has been for the last more than 30 years the principal modality by which clinicians like you and I target for patients whom we are managing clinical practice to decide on how to initiate therapies, when to initiate, and how aggressive to do so. And on top of that, this is what the parameter is used by regulatory bodies to try and decide whether this molecule that they are is effective at achieving achieving glycemic control and glycemic. So remember, it is the principal modality by you and I practice. First things, A1C needs to be standardized. That means not any single laboratory can just open up shop and run any kind of assay. Hey, you can use my A1C result to decide whether it's controlled or not. It has to be standardized to this term, National Glycohemoglobin Standardization Program, a mouthful, SP. And when standardized, we realized that it actually correlates very well clinical outcomes, largely from 2 key landmarks, the DCCT and the UKPDS, which all are familiar with. That is therefore the reason why A1C is utilized, because it has strong, significant predictive value for predicting complications. That in fact, if we were able to lower A1C, that the microvascular complications in the immediate short term will be reduced. That's the benefit, straight up front. And for macrovascular complications, it can be reduced in the long term, what we call the legacy effect. And therefore, again, to re-emphasize that A1C is the foundation of our practice, because the evidence that has been built up over many years that in fact A1C increase correlates with complications. These come from observational population studies, and that increase starts what we know as normal value A1C of 5 to 6%. And that, okay, you think to yourself, yep, okay, there's a correlation, but does the reverse hold true? Meaning, if we lower the A1C, do we or can we reverse complication rates? And the answer is yes. Let me show you the data. This is from Singapore, a population sample, more than 3,000 over individuals, and you can see on the x-axis the A1C level, and it's correlated with the incidence of retinopathy. In the black column, any retinopathy, the gray columns mild, and in the white column, moderate retinopathy. And you will see straight away that that increase starts when the A1C goes above 6.5%. And therein reason why it was chosen at 6.5 for us to make that diagnosis and to consider individuals at higher risk of developing diabetes with microvascular complications. Another population base from New Zealand in this instance, and it includes a huge number of individuals with type 2 diabetes, 48,000, right? And you can see the x-axis is going all the way down to 6%, and you can see increasing cardiovascular event rate with increasing A1C. And now we move to the interventions. When you intervene, and this is the famous UKPDS, with improved A1C, you can significant reduction in all the parameters that we recognize as diabetes related. Myocardial infarction by 14%, microvascular complications by 37%. Every 1% A1 correlates with reduction in diabetes related complications as we know it. This is also the UKB. What am I trying to illustrate? That there is a continuum of risk, that in fact there is no threshold below which you can say, need to actually lower anymore because you don't see any value or benefit. No threshold. The lower you get, the better the outcome for that individual. A last slide on UKPDS, something very familiar to you. This is emphasized that apart from the microvascular complication rate that is reduced, myocardial infarction as a vascular outcome is also reduced. This is the DCC from the type 1 studies. And you can see again, very clear, similar to you saw in the UKPDS. The higher the A1C, the higher the rates of retinopathy, nephropathy, and neuropathy, everything that you recognize as a diabetic complication. And the higher the A1C, the higher the rate of microvascular complications. This is a meta-analysis of the 4 landmark glycemic trials, and you will see there it's ACCORD, Advanced UKPDS, ADT. And then when they meta-analyze all these patient-level data over a long period of time of 4.4 years with a crude 2,000 over vascular events, you will recognize myocardial infarction is reduced 15% for every 1% reduction in A1C. 15% in myocardial infarction for every single 1% A1C we can reduce. And therefore, really, remember guys, A1C is what brought us here. We use to diagnose our patients. We use it to decide on treatment regimen. We need to use the targets to drive our management. Here we are. A1C is all over the CPG. Screening tool for the purpose of diagnosing diabetes. And you've seen this, or it's not different from the previous CPG. What is the reason? What are the aims of managing our type 2 diabetes? That's because we want to improve their lives, we want to reduce complications and prevent them from dying prematurely. And for that, you must remember the ABCs. The ABCs are A1C, blood pressure, and cholesterol. Remembering that, again, diabetes is not just glucose alone, but A1C is still in. And so again, all the algorithms A1C to help us decide how to manage our patient. For the newly diagnosed, newly recognized patient, we have recognized if you depend on what level you come with, you may want to start different. On follow-up, we still use A1C. Depending on how above the target you are, you either add one therapy or two therapies, or in fact, what you've just heard from Professor Rohana, initiation of GLP-1 or insulin. And specific patient profiles. Please, let me just highlight that top panel there, that if A1C is not individualized, you use the rhythm to decide what therapies to give your patients. Remember, reaching A1C is still a priority. Perhaps you think about it and say, you know, SP quite difficult. No, not difficult, right? The decision depends on the patient in the journey, and it will, as you've heard from multiple other speakers earlier on, depend on the patient you are seeing. It will depend on the feasibility, economics, the burden of comorbidities, and certainly to take into account the patient's personal preference. These are the tests that we have recommended depending on the patient profile, and this is not different from what was in the previous CPG. So my last slide, is A1C still important? Is it still? Yes, the answer has to be. It continues to be the principal model by which we target our patients in clinical practice, in monitoring, drug therapy, and for regulatory purposes. In fact, I would suggest that A1C is the heart and foundation upon which diabetes management is built. Much. Okay, that brings us to the end of the hot topic session. We've had talks that have been presented to you, rapid, as you can see, and we are really way ahead of time. So if I could start the polling, since we are so ahead of time, those of you who question and answers are going to come at 4 p.m. I'm sorry, we're going to start. And we will also, because we are doing so well, probably finish by 4 p.m. so that you can go out and do your exercise, right? So there have been incredible questions that's come through. Thank you very much. Some of them are difficult to answer, so we shall skip those. And when it comes to policy and availability of treat modalities, please, we would like to apologize ahead of time. Can I ask Professor Wan Mohamed to show himself? Yep. Okay. So the speakers are there. You can see them all, including Prof. Wan Mohamed, my co-chair, as well as Dato Zanariah as well. And my recommendation is to enable everybody to get a chance to give their opinions to the lot of questions that have come through. We're going to rotate that are going to be posed to each of these speakers, take it one step at a time, and then we'll go round and round so that all the speakers will have a chance to answer. So if I can ask Professor Wan Mohamed to start the ball rolling. The first question of Prof. Mafauzy, who talked to us about reducing diabetes. Prof. Wan.
Thank you, Prof. SP. Let me pose question to Prof. Mafauzy. And many of them are overlapping each other, but majority of question confined to common use in prevention of diabetes mellitus. When to start metformin for prevention of diabetes in pre-diabetes, what is the dose, minimum dose, and what is the duration of treatment?
Thank you, Dr. Wan. I think for the first question is that when metformin. As I mentioned in the lecture, in the high risk pre-diabetes, where for instance, they have both IFG and IGT, they have pre-diabetes and obesity. You can at the same time as lifestyle, i.e. diet together with lifestyle. But together with metformin. But for those patients whom you want to start on lifestyle first, i.e. and physical activity, getting them to lose weight, then you wait you can continue with that for 6. After 6 months, you remain pre-diabetic, then you can start metformin. So, i.e. you can start a metformin if risk at diagnosis together with lifestyle, or you can give them an option treatment for 6 months, failing, i.e. they remain pre-diabetes, to start them on metformin. Okay? Dose of metformin, we recommend you start with the minimum dose of 500 milligram a day first, and then titrate a maximum tolerable or the maximum of 2,000 milligram per day. When you titrate, the aim of pre-diabetes is to reverse them into normal, i.e. get them to achieve a fasting blood glucose of less or an HbA1 of less than 5.7. If the person say on 500 milligram and they still have fasting of maybe 6.3, okay, you can dose of metformin, or the A1C of 5.8, you can dose of metformin until you reach a fasting of less than or an A1C of less than 5.7. So that's your target. And then how long? And then if patient is able to get the expected loss of 7 to 10% of the initial body weight, and then remain normal glycemic, okay, you may down titrate the metformin and even off the metformin if the patient can remain normal glycemic without me. But if the patient, after a trial of putting the patient off metformin, they revert back to pre-diabetes, then perhaps you need to start longer on metformin. Okay, so that depends on whether the patient can remain normal and can be off metformin. Okay, so that's a decision.
Thank you, Prof.
Right, so maybe I'll carry forward with the question posed with regards to continuous glucose monitoring in with the current technology. So I get all the questions, and I'd like to actually pose them to Dr. who presented just now. There are questions, availability of them locally. So what I may say and answer is that yes, flash glucose is available as of mid-December last year. Can be actually purchased online on Lazada. Yeah, but Dr. Foo, I think important to clarify is the indication when consider using CGM. There was a question with regards to using it in GP practice, and there was also a question which discussed the possible using it in pregnancy. So whether you could give some kind of indication when our audience doctors use continuous glucose monitoring and even glucose monitoring.
Thanks, Anna. So as I mentioned during my lecture, just like talking about when should we consider CGM in our patient. So short, CGM obviously is indicated if someone has deemed to have wide glycemic variability. This in particular referring to patient who is typically on multiple insulin injection, or they are on the insulin pump. So there was a lot of limitations when we just perform 5, 4 point or 7 SMBG. So a continuous glucose
monitoring clearer picture on to how to target these on unrecognized hyper and hypoglycemia. So it can be CGM has a particular role in the women with pregnancy because we know that glucose monitoring, the target tend to be even lower for pregnant women with diabetes. And there has been some study of quite a number of CGMs are being performed in pregnancy. You can look at concept study. So this definitely had a role to kind of help us to kind of achieve the glycemic targets in pregnant women.
One thing is to consider whether we would use it sort of earlier on. With some little experience of using it, growing experience of using it on maybe just people on insulin or sometimes combined OAD, not within the categories that you have mentioned just now. I've realized that patients can actually modulate or modify their lifestyle and their diet and actually get to and be motivated, in fact, to actually get better numbers, and eventually leading them to getting actually very much better A1Cs and sometimes reducing their insulin requirement.
Yeah, absolutely agree. I mean, I have patients who is not using insulin or an oral agent alone, and they are using a fast CGM. So it depends on the individual patient. So it's also very useful motivational tool, as I mentioned earlier. When you use a CGM, you read your glucose continuously. You learn a lot from how different type of food react to your sugar. So it depends on what's the aim and what's your engagement or commitment toward your self-care. So there is no such thing as whether you can or cannot. I mean, of course, the devices are not routinely reimbursable. So we all have to come down to look at the resource setting, whether because you have to come up with out-of-pocket costs, so that's the limitation here. But all in all, I forgot to mention that the use, or somebody asked about the role of CGM use, whether it can be managed in a primary care. Definitely, yes. So as long as the healthcare provider in the primary care, as well as the patient, are willing to learn, to be educated on how to make use of this technology, definitely not an issue. Yeah.
Thanks, Foo. I think what we'll do is we'll go on to the next sort of session and the questions that come up from there. So I'd like to pose some questions to Dr. Florence, way there in Kuching. Florence, specifically, I think it was about the lower target of blood pressure in diabetics. And there was some concern why we would not go to below 130, and also the concept of the J curve. Florence, would you want to comment on that?
Yeah, I think this is a very important question. Mainly our target for general is not below 130 because meta-analysis has not shown further benefit in terms of lowering blood pressures below 130 or 70, except for patients with high risk of stroke or diabetic kidney disease progressions, those with heavy proteinuria. In addition, there are also in meta-analysis, we've shown that in some high-risk patients, there is increased risk of adverse event as well as treatment discontinuations. So if there is an increased risk of side effect, for instance, in at-risk patients who are elderly or with underlying cardiovascular disease, treatment discontinuations is actually associated with worse outcome. So in general, we do not recommend treating below 130 because there's no evidence for further benefit in terms of cardiovascular risk reductions or mortality risk reductions. And there is increased risk of adverse event, as well as in some study, very high-risk patients increased mortality. However, for patients with high risk of recurrent strokes or heavy proteinuria, then we can treat it below 130, but not lower than 120, provided that it can be well tolerated.
All right.
Thank you very much, Florence. We'll go on to NAFLD and type 2 diabetes. There have been a lot of questions coming through just to show how interested the audience is on this topic. So I've just chosen, just to start off, is why the prevalence is so high for NAFLD in type 2 diabetes in Malaysia, Prof. Chan, and is there any ethnic differences? And how would you sort of like use AST and ALT in terms of its sensitivity to detect NAFLD? Prof. Chan?
Thank you, Prof. S. P. Chan, for the question. In fact, the high prevalence of NAFLD in diabetes patients is not unique to Malaysia. As you have heard from the talk earlier, NAFLD is considered as the liver manifestation of the metabolic syndrome. So in whatever setting, if you have a high prevalence of obesity and metabolic diseases, you would expect a high prevalence of NAFLD. So as we all know, in Malaysia, 1 in 2 adult Malaysians are overweight or obese, and 1 in 5 adult Malaysians are actually have diabetes. So we can expect a high prevalence of NAFLD here as well. And in terms of ethnic predilection, certainly Malays and Indians have a higher prevalence of NAFLD compared with the Chinese. There have already been several studies consistently showing that. And this racial predilection can be observed as early as young adulthood. So we also published a paper on that not too long ago. In the context of using ALT and AST for diagnosis of NAFLD, so in patients with elevated ALT and AST, there is a high likelihood that this patient actually have NASH or non-alcoholic steatohepatitis, which is the more severe form of NAFLD. So of course, we have to exclude other common causes of elevated serum liver enzyme as well, such as drug-induced hepatitis, hepatitis B or C infection. But otherwise, in the presence of NAFLD, elevated serum liver enzyme suggests strongly that the patient has NASH. On the other hand, if the ALT-AST level are normal, these do not exclude NASH. Patient can still have NASH. So as a safety net, you can use a simple fibrosis score, which I've spoken about earlier in the talk, that you can use to see if the person has advanced liver fibrosis and therefore refer the person accordingly.
Thank you, Wakyong. So the next speaker was...
Next speaker from Malaya, yeah.
Yes.
Question to Prof. Malaya. This more of the getting further clarification by the audience. A question is, periodontal disease is complication of diabetes mellitus, or periodontal care improve glycemic control? They need further clarification from you, Prof. Malaya.
Thank you, Dato Mohamed, and thank you for the question. Yes, I think this periodontal disease and diabetes is not something new. It's been there for a long time. It's just that it has not been highlighted. And the complication of periodontitis it has been shown back in early 90s with one study, and we know if the sugar is not well controlled, of course there'll be a complication, infection like periodontitis. But at the same time, we also know inflammation of the gum or gingivitis, periodontitis will also cause abnormality in the metabolic control, and namely in this situation is HbA1c or diabetes. And it goes both ways. If it's not well controlled, you tend to get complication, periodontitis. And if somebody has gingivitis or periodontitis, then it will worsen the glycemic control. So it goes both ways. I do hope that answers the question. It's because the underlying inflammation.
Yeah, thank you, Ronala. The question to Datuk Malik. Datuk Malik, are you ready? You mute yourself. Please unmute.
I feel like I'm going for my exam viva. Okay, let's go.
Okay. The question is, why benefit for CVD reduction, risk of CVD reduction, confined to EMPHA and canagliflozin, not the others gliflozin?
I think this is a question the whole world is asking. Why only the two? I don't think there's an answer to that. Some people talk about duration of trial. Some people talk about different populations and so on. But I think, we've been to meetings and really no one can answer that question, why EMPHA-Reg was positive. And some people, contest that it's actually the population, the way the study was designed, add-on data collection later on and so on. So don't know. No specific answer as to why.
Just another question, additional question. Can we use SGLT2 inhibitors to treat peripheral vascular disease?
peripheral vascular disease. Not that I've seen any data. Not that I've seen any data. Most of there are one or two trials that looked at peripheral vascular disease as part of a cardiovascular continuum, but specifically looking at peripheral vascular disease risk reduction, not sure.
Okay, thank you very much, Malik. We'll move on to diabetic kidney disease. So the next questions are to Prof. S.K. Lim. I'll start off by asking, you've given us such incredible news that all of us are so excited. Are there really any contraindications for the use of SGLT2 in patients with diabetic kidney disease? And can all of them be used, everyone that we have available in Malaysia? And is there a dose change when you have a renal impairment?
Okay, so thanks, Prof. Chan. You asked me 3 questions, right? so I think the first one, in terms of contraindication, I would say SGLT2 is an interesting molecule that we have to learn how to use it properly. So in terms of contraindication, I would say is more of a relative contraindication. So I can think of a few scenarios where it might be relatively contraindicated. So the first one will be if a patient experiences an excessive dip in eGFR after initiation of more than 30%, and if you are not able to identify the potential contributing cause, and that might be an contraindication. But I have to point out to you that based on the trials as well as clinical experience, I think this is very rare. And in Credence, it was quoted as about 1.4%.
patients who were at risk of getting retinopathy were those with long-standing diabetes of more than 10 years, HbA1c high, above 9% at least, and those who had pre-existing diabetic retinopathy. So only with the use of semaglutide though, so the other GLP-1s do not seem to be indicating the same. And also the fact that those who do not have underlying retinopathy, probably not so much at risk. So if you were to ask me, do you need to screen them? Probably not prior to starting semaglutide, but at some point you might want to recommend them to go for screening anyway, because that is the standard treatment and management of type 2 diabetes. Thank you.
There was another question, Rahana, with regards to the injectables about how to minimize weight gain while on insulin therapy. I mean, that's a very practical and important topic, whether you would want to, just give the basic sort of thoughts on that.
Sure. Okay, so obviously we are very concerned about those that we initiate insulin. We have had, and I'm sure Dr. Zana, you are also concerned about those with very high doses of insulin. So the main concern is really about the understanding of what the insulin does to them. So diet and lifestyle is actually first line treatment. So reinforce compliance in terms of understanding the timing and understanding the amount of carbohydrate that they're taking. Somebody asked whether alcohol is allowed at some point, but probably that's something you want to avoid, for example, to maintain good glycemic target. But other than that, in combination, if it's not contraindicated, and again, I put emphasis in that if the other oral medication or even injectables are not contraindicated, you might want to use in combination with the SGLT2 inhibitors or GLP-1 receptor agonists. So that will provide a synergistic effect in a way in maintaining the weight low and achieving the good glycemic target that we all desire.
Yeah, interestingly that you brought the topic of SGLT2 inhibitors, and I had recently looked at the sort of a post hoc analysis of the EMPEREC trial, and it showed that the patients who were actually put on an SGLT2 inhibitor, so many more
to see what are the that the class of drugs give us protection of the target organ, irrespective of what levels of A1C that were achieved, and therefore suggesting that A1C is not important to actually try and get them to target, because you're going to get the target organ protection in any case. So that is where I feel is a little bit of a dilemma. Yeah. And I'd like to reiterate again and again, emphasize that A1C is still very important to get to patients. Whenever the patient's A1C is dropping, we worry about hypoglycemia, and that is the key concern. If you are using drugs that don't cause hypoglycemia, I would generally be a little bit more confident and not worry too much, right? Okay, Juan, I think we have done the first round. Let's continue with the rotation. Second round with Prof. Mafauzy.
Prof. Mafauzy, the question is, what is considered high severity risk in our guideline?
Well, as mentioned, the high risks are, one, if they have obesity, two, if they have combined IFG and IGT, the other is they have pre-diabetes and young here is less than 60 years old, or if they have a fasting plasma glucose of more than 6.1, and an HbA1c of 6%, and also if they have a history of gestational diabetes. So these are considered as high-risk pre-diabetes, i.e. where we recommend the use of metformin together with lifestyle. For the others, the so-called lower risk pre-diabetes, you can start them on lifestyle therapy first, and then if they achieve normal glycemia, then that's fine. If they don't achieve normal glycemia, i.e. they remain pre-diabetes, after 6 months, then we also recommend that they be started on metformin.
Okay, thanks.
Okay. So there are some more questions, Dr. Foo, with regards to the glucose monitoring section. And one of them was quite a general but important topic to probably have a say on, is what would be the most optimal frequency of monitoring glucose, yeah? That is quite a broad question. And following on to that, with the more modern technologies, was this issue on how really accurate is the flash glucose monitoring in terms of giving you an accurate blood glucose measurement as compared to capillary glucose. So maybe we can discuss that.
Okay, so the frequency of glucose monitoring, there is no one size fits all. It depends on the individual patient. So to say simply, of course, you want to motivate your patient to monitor the sugar as frequent as they can. But also at the same time, there is also other factors involved. You can't be breaking your finger too often, so if you're using a conventional SMPG. So basically, the general rule is if your patient is on oral alone, oral anti-diabetic therapy alone, so generally we recommend them to do a 4-point sugar at least once a week, more is better. So that's fasting and 2-hour post-meal. And so that is if the patient is on injectable or patient is on an insulin pump, CSII, so then you should monitor the sugar more frequently. And that will come into the fact you may want to consider monitoring your sugar continuously, and that comes the role of a CGM here. So in which that you see your sugar continuously 24 hours a day throughout. So yeah, and in terms of the issue of accuracy, yeah. So when coming to CGM, a lot of people will ask you, how accurate is this CGM devices? Of course, all these devices, before they were approved, they have been tested against the venous blood glucose, and they have to follow a certain criteria. The range here is to be within 10% to be approved, so plus minus 10% compared to the blood glucose. So of course, what you do need to understand, and I understand in my previous slide just now, there are certain situations where the percentage is slightly higher, typically in the first 24 hours of sensor insertion, and also when your glucose is in a low range. So so that reading the deviation may be slightly more than 10%, up to 12-13%. But I think the main point here I want to emphasize is when we use the CGM device, whether it's flash CGM or personal or professional CGM, it's not so much about the what's your absolute sugar, but it's about pattern recognition. So you perform CGM on yourself, you generate the report, and then you can see your trending and pattern. So that is actually the main thing that help you to manage your diabetes together with your healthcare provider. Yep.
Sir Foo, just a mere mention because of the, my recent experience using flash glucose monitoring. Apart from the indications that you mentioned clearly, is also selecting patients that are actually keen and interested to actually know their sugars. I've had the experience of putting the flash glucose because we were in a pilot study in some of our MOH centers, including yourself. And in certain patients we inserted it on, and they couldn't really care very much about knowing their blood glucose. And some are actually just flashing the right thing, 3 times a day or 4 times a day, whereas we had some very, very sort of interested patients who were really wanting to get knowing their glucose, actually scanning or flashing up to 30 times a day or more, and thus making it possible for them to actually make the decision and try to modulate their lifestyle. So that's one other thing as well. Not every patient would be keen to know very much and can cope with that. So an interesting observation I noticed. There was a question about whether it's available in KKM, and since I'm working in KKM, well, that's a difficult thing to say. We both work in KKM, but I think in our centers, if there was a clear indication in terms of difficult situations like frequent hypoglycemia or frequent DKAs or that kind of situation, I think we would do our best to try and get it available for that difficult patient. Okay.
Anna, can I ask you something?
Yes, Malik.
I think it's the cost that limits the use of the flash in the Libre and so on.
Yes, there was a question on cost, which I deliberately didn't answer. I think if you look on Lazada, the cost of the sensor, which you put, just under your upper arm, which you can use for 2 weeks straight, if it fixes and adheres on nicely, is about 280 ringgit Malaysia for one sensor. That's not with the reader, that you can also use for monitoring glucose as well. Yeah, Malik, sorry to interrupt.
No, I was just saying it doesn't, actually it's going to cost more than that, because more often than not, it doesn't quite last 14 days. After 10 or 11 days,
I used it twice, Malik, and it lasted 14 days.
14 days, lucky you.
Okay.
More than 14 days.
Yeah. So again, I think we noticed that in the pilot study as well, that there were situations where it, didn't last that long. In fact, problems of, yes, definitely. You need to take care of that.
Next question for BP and lipids.
I didn't notice very many.
Yeah, I didn't have that many questions, so maybe we'll...
There were not too many questions on BP and lipids, Florence.
Very well presented, Florence.
Yeah.
So I think I'll move on to Prof. Chan, Wah Keong. Right, quite a lot of questions, and they want a position of all these other supplement therapies that have been touted in the media with regards to tocotrienols, vitamin E, milk thistle. What is the scientific evidence to show NAFLD can be managed appropriately? Wah Keong?
Okay, so thanks, Prof. S.P. Chan, for the question. So first of all, I'd like to say that there's currently no approved treatment for NASH. And the current sense of things is that we do not need to give pharmacological treatment for all our NAFLD patients. In fact, we should be targeting those with NASH and more severe fibrosis for pharmacological treatment. As mentioned in the CPG and the earlier talk, lifestyle intervention is still the foundation for treatment of all our NAFLD patients. We have seen clearly that weight loss of at least 10% can result in 90% of patients with NASH having resolution of NASH. and 45% of patients even have fibrosis improvement. In that sense, NAFLD and diabetes are really the two faces of the same coin, or two faces of the same monster, if you like. We have heard earlier from Professor Mafauzy and Dato Zanariah as well about how diabetes can actually be reversed by lifestyle intervention and weight loss. So I think it is the same for NAFLD. Our current understanding is lifestyle change, a hypocaloric diet, exercise leading to weight loss is really the mainstay for NAFLD treatment. As for supplements, there are some evidence for supplement use in NAFLD, but of course, they do not meet the high standard of scientific rigor that we need to enable them to be listed for treatment of our patients. For example, vitamin E has been shown to be useful for biopsy-proven NASH patients. It helps to reduce steatosis, inflammation, and ballooning, significantly greater than placebo. However, its use is limited by concern about conflicting report of increased all-cause mortality, as well as a slightly higher risk of prostate cancer among young men. For other supplement that is very popular include silymarin or milk thistle. We have ourselves done the study on silymarin for treatment of NASH. We did find that a significantly greater proportion of biopsy-proven NASH patients had fibrosis improvement compared with placebo, but that was only observed in about 22% of the treated patients. So not all patients will benefit from it, although we know milk thistle is a very safe supplement. But what I would like to say is that there are currently a lot of ongoing clinical trials looking at pharmacological therapy for NASH and fibrosis, and all those results are still eagerly awaited. But some of the compounds that is showing promise is, for example, a GLP-1 agonist. There's a paper that was published end of last year in the New England Journal of Medicine on semaglutide 0.4 milligram daily versus placebo, resulting in significantly greater improvement, greater resolution of NASH. There's also another paper published in Diabetes Care about 2 to 3 years ago already. It's the ELIF study, liraglutide for NASH. A significantly greater proportion of patients actually had NASH resolution, and significantly lower proportion had progression to cirrhosis during the study. And we also have got study on use of SGLT2, empagliflozin, in patient with biopsy-proven NASH. A small pilot study, we found that a patient has significant resolution, significant improvement in steatosis, as well as improvement in ballooning and fibrosis. So all these are very exciting, and we are waiting for more results of study on SGLT2 and GLP-1, as well as other compound for the treatment of NASH. So I think that's all from me, Prof. S.P. Chan.
We'll like to hear from Prof. Wan. You have to pose the next questions to Laila and Malik.
There is no more question to Prof. Laila. Probably your lecture is crystal clear. Question to Prof. Malik. Is there any role of SGLT2 inhibitors and GLP-1 analog receptor antagonists for management of diabetes in acute cardiovascular setting, i.e. STEMI or non-STEMI?
Okay, as far as the trials are concerned, there isn't...
What are all the modalities?
I can hear SP Chan in the background. Okay. As far as the trials are concerned, they didn't actually separate between STEMI and non-STEMI, but there is data in the background looking at infusions of GLP-1. Those days it was exenatide in patients who have acute heart failure, as well as acute coronary syndromes in animals and so on. So as far as I'm aware, there isn't much data to separate between STEMI and non-STEMI at the moment.
I said in the clinical trials of CVOT, the entry criteria for patients was at least a duration of, was it a few weeks at least?
Depending on the trials, they varied.
Yeah, yeah.
The question here is acute setting, probably those recent, very recent, yeah.
Okay.
Okay, next question.
All right, I think we kind of got lost already. Never mind, let's leave it. Rohana, I'd like to ask you the question which is very pertinent. As mentioned by Zanariah, a lot of FMSs are using a lot of insulin. So one of the questions that came through is what do they do if a patient is already on very high doses of insulin, daily total dose, and yet the A1C is not at target? What should they do?
Okay, thank you very much, Prof. I think we kind of answered that question partially in the previous question, but anyway, so I would say first and foremost to go back down to basics. Okay, so fundamentals in terms of compliance, adherence, whether the patients are actually taking it or patients are actually lying to you that they are, and going back, taking on what Chee Kiong was saying, that it's lifestyle and diet. So the patient should be properly addressed, properly advised on what kind of food they need to avoid. I do have a few patients who have successfully lowered their HbA1c to less than 7%, and when they were on basal bolus insulin purely by dieting alone. But of course, that is the wife cooking for the husband. I'm not sure vice versa. But anyway, so in addition to that, other things that I would actually advise is to look at the pattern. So if you have a patient who has been with you for a long time and you're suddenly experiencing this rapid escalation of HbA1c for no obvious reasons, do not fail to recognize the other signs of ischemia, underlying infection, and even malignancy. I have had experience with a few patients who had underlying breast cancer that the only manifestation is the increase in the glycemia. So other than that will be, again, going back to the combination therapies, I think it is very, very important to understand the pharmacotherapy of each of the medications that we have and to kind of use them in combination so they address a different pathophysiology of the complex nature of diabetes. So I can use SGLT2 inhibitors at the background with a DPP4 inhibitors and hopefully, and of course, GLP-1 receptor agonist if it is available in your facility to facilitate achieving the glycemic target.
Thank you so much, Rohana. It's still important to re-emphasize those points. I'd like to, again, we're going to throw out the rotation already because we've forgotten who is supposed to do what. SK, the question that I posed you, which is, do you change dose for SGLT2 in renal impairment? And there was one more question that I posed to you with regards to, what about RAS blockers?
All right, thanks, Prof. Chan. Okay, so there are two questions. First, in terms of dosage. So if you look at all the SGLT2 in the market, basically canagliflozin is the only one that uses a different dose for CKD versus non-CKD. So for Cana, we use 100 milligram for CKD, and non-CKD, we use 300 milligram. But for all the other SGLT2, essentially, you don't see the difference in dosage for CKD and non-CKD. So for when the patient have a progression in terms of the kidney disease, generally we don't really have to cut down the dose. Of course, we understand that the HbA1c reduction efficacy is actually reduced in CKD. But if you look at the two trials, renal outcome trials for SGLT2, namely the Credence as well as DAPA-CKD, essentially patients actually was maintained on the same dose throughout until they reach dialysis. Then only they were advised to stop. So of course, patient can choose to stop early if they actually want to. So that is actually the basis of the recommendation from KDIGO to say that in patients who have GFR of less than 30, if they are already on SGLT2, you don't really have to stop it. You can actually only discontinue when the patient actually started on dialysis. All right, so that is the first one. The second one, I think somebody actually answered that since SGLT2 data is so impressive, do we still need RAS blocker? The answer is yes, even though I don't own any share in the RAS blocker company, but the answer is definitely yes. The reason is because you look at the mechanism of action of the drugs, both the RAS blocker and SGLT2 basically complement each other in terms of the effect on the kidney, particularly. So RAS blocker, if you remember in my lecture, I highlighted that it basically opened up the efferents arterioles, and the SGLT2 basically causing vasoconstriction of the efferents arterioles. So basically both contributing to the reduce in intraglomerular pressure. Right? Of course, if you do have a patient who cannot tolerate RAS blocker, is it all right for you to give SGLT2? The answer again is yes. because, of course, we do not have a specific trial in terms of that. But if you look at one meta-analysis that look at the 3-CVOT for SGLT2, they do identify about 20% of patients who will not put on RAS blocker, and they do a sub-analysis. And this group of patients, they still enjoy a benefit of risk reduction about 30% in terms of renal outcome, even though statistically it was not significant because the number was too small. But it does actually benefit the patient, even though the patient cannot tolerate the RAS blocker a lot of time because of hyperkalemia, you can still put them on SGLT2. Yeah.
Thank you very much. As the head prefect here, I'm going to call this to a close soon, not yet. I'd like each of the persons here, panelists as well as co-chairs, to perhaps have a final statement that you'd like to give to the audience who have been so kind to join us this afternoon for the last 2 hours plus, listening to us on the highlights of the CPG. So perhaps I will start with Prof. Mafauzy. We'll go down the line and then end with Mohamed and Zanariah to give some final statements before we say thank you. And I must say thanks to our sponsors. Please, Mafauzy, please.
Right. Thanks, SP. I think the highlight of this new CPG is essentially the new data on reversing diabetes. We have to talk about preventing diabetes from pre-diabetes before, which we emphasize again. Now, I think this CPG highlights on the fact that the recent studies to show that people with recent onset diabetes, if you can get them to lose weight, okay, reduce the insulin resistance, you can reverse their diabetes, i.e. they can be normal glycemic without any medication. So that's the highlight of this CPG.
Thank you.
Hi, yeah. So just want to congratulate everybody for making this launch a successful one. So my final message for everybody would be, do keep up with the diabetes technology. It is evolving rapidly. Every few months you see new things. So as a healthcare provider, we need to be attuned and be familiar with the technology and make use of it. And hopefully in the near future, the cost will come down and that will be able to benefit more patients. Thanks.
Lauren.
Hi here from Sarawak. So I think, thanks again, everyone. I think management of type 2 diabetes can be easy. Just remember lifestyle and ABC. A for HbA1c, but don't stop at there. B for BP and C for cholesterol. So with that, I hope that our patients will have much reductions in terms of both micro and macrovascular complications. Thank you.
Forgotten already. I think
Professor Chan.
Yes. So first of all, I'd like to thank Prof. SP Chan for inviting me to contribute to the NAFLD section, which is occurring for the first time in the type 2 diabetes CPG. I think we are one of the first few to do this, and I'm sure many countries in the world will be following suit. And just to all to remember, whenever you see a patient with diabetes, remember to look for the other phase as well. And hopefully we will be seeing less of our diabetes patient presenting for the first time ever, with NAFLD presenting as a variceal bleeding, liver cancer, or decompensated cirrhosis in the near future. Thank you very much.
Laila?
Yeah, hi. Thank you, Professor and Dato Zanariah and the rest of the panelists. My message is very simple. Apart from reducing blood sugar or A1C in people with diabetes, we also want to see their lovely smile with a nice gum and nice teeth. That's all.
Thank you, Laila.
I like that message, Laila.
Yeah, happy people, happy smile.
Yeah, SP. It's me, yeah. It's still on Laila.
No, it's you.
Oh, okay. Okay, the first thing I'd like to say is SP, Zana, Prof. Wan, you've done an incredible job. I mean, you drove us over 1 year. We managed to produce nothing to something really wonderful. I mean, the amount of work that we had to put in, all of us individually and as a group, I think was quite phenomenal. And you managed to rein in about 70 odd people and keep them whip them into shape. That's an incredible task. The CPG is something I am proud of. I mean, it looks really wonderful, comprehensive. It also teaches us that, diabetes now, there is hope beyond just glucose. We can, we help the heart, we can help the kidneys. There's a lot more we can do than from previous times. So congratulations, all of you. I'm proud to be part of this. Thank you.
Thank you, Malay. Next, I think Sukun, I think.
Thanks, Prof. Chan. I enjoyed this process very much. So my one message is, I think even though we have seen a new class of drugs which can actually have huge impact in terms of organ protection in a type 2 diabetes patient, but more and more people will be using this drug, but I think we have to learn how to use it right and use it appropriately. Yeah.
Thank you so much. Zanariah?
Right, so I was talking about early diabetes, and I think the challenge for us is actually how to make our colleagues in primary care, especially dealing with 80% of the diabetes problem, diagnose diabetes early, make the right treatment decisions with the right medications for diabetes early, so that the later outcomes for patients are actually more secured. So this becomes a challenge, especially for public care. So we will fight to see whether we can get better access to better medications, and of course that doesn't come without other things like patient education and improving awareness and all of it together. Thank you.
Thank you very much, Zanariah. Rohana?
Thank you very much. I would like to echo Dr. Malik's thoughts. Congratulations to the whole committee for making this a possibility. But just as a background work, that the CPG is developed based on current evidence and data, which is continuously evolving, and what we speak about now may not be valid in a few years' time. However, it is also, I'd like to emphasize that any guideline is a guideline, as it says, and really the key word to me is individualization. So there are many treatment of medications for diabetes out there, so it is about choosing. In terms of injectables, there's only two, the GLP-1 and the injection. I'm sure our colleagues out there, the family medicine, for example, may be a bit anxious about introducing injectables. However, I think in current times, patients are very much aware about what the importance of insulin, and as well as that the newer injectable with the GLP-1 agonist, which is limited by cost. However, if you feel that it is beneficial to your patients in terms of cardiovascular and renal benefits, take time to discuss with them and explore the options for them to be able to get it. So, the best for the best. Thank you.
Thank you very much, Rohana. That's very well put. For myself, I think A1C still matters. It's still relevant. If anybody who doesn't say so, you'll see me coming to you, right? But before I finish my statement, I'd like to again remind you that we are only the face of the few people who have been able to come forward, but the whole task force, as Malay has said, involves about 60 over of us. We'd like to say thank you to them for also assisting us in making this document possible, particularly the family medicine specialist people like Sri Wayu, like Mastura, like Faisal, who have actually come together to help us with this document. So we must not forget them. Wan Muhammad?
Yeah, thank you everybody, in particular SP for your hard working. My only hope is that the event is not ending here.
Yes.
We should go down to the ground, helping our healthcare provider how to manage diabetes mellitus. I think MEMS have programmed to educate our healthcare provider in using guideline. Thank you.
Thank you, Wan. Zanariah?
I thought
You said already?
I said, well, again, I echo, what Prof. SP and Prof. Wan said, and everyone else. It's a great teamwork, but, I am really, really grateful for our lead, Professor SP Chan, to take us right through and actually materialize with this guideline. And we will work ahead with all of you, to improve care. Yeah.
As you have mentioned, there are plans to roll this out. We will be planning webinar series where we will put all these topics that are in much more detail. We'll be coming to you guys for assistance, and we are already in the midst of preparing our training module with PowerPoint presentations that will be made available to everyone. In fact, the CPG is already online in the Academy of Medicine website, as well as the Ministry of Health. MEMS apparently is behind everyone else. I'm actually embarrassed. Oh, it's up already. Okay, it's up already. In fact, I heard from our endocrinologist, cardiologist send them the CPG. Oh, allow it. Okay. With that, I have some final words to thank. Please stay on the line. We must thank the key people, please. Okay, this is where you get your CPG points, CPD points. This is for the doctors. Don't worry if you don't capture it. It's going to loop after this. For the pharmacist, this is your event ID. Again, it will be looping. Don't worry if you don't capture this. And final, but certainly not least, we have to acknowledge our pharma corporate sponsors who have made this event possible through their sponsorship in order to make this virtual event possible. Thank you very much to all our pharma supporters. With that, thank you very much. There's a survey. Hi, before you get your points, survey first. Okay, thank you very much.
Thank you.
Good day.
Typical SP.
Okay.